Hello, everybody. Um, uh, Dr. Richard Wender, and I really want to welcome you to this roundtable on the webinar. I'm the chair of the National Colorectal Cancer Roundtable. We have a tremendous group of panelists who've joined us today, really as a follow-up from the webinar that we did a good number of months ago, as we were facing a marked reduction in screening rates and looking to see how we can get them back up again. And we thought this was a really good time to look at the current landscape 1 year into the pandemic. So welcome to all of you, and let's get going. So the purpose of today's webinar is to look at progress on the recommendations that were outlined in the playbook that we talked about the last time we were all together, reigniting CRC screening during the COVID-19 pandemic. We want to talk about the issues that we're still working on, that we need to understand better, we need to prioritize, that demand collective action. And we also want to really get down to specifics. What are some of the initiatives, concrete examples, promising activities that have proven successful in addressing the impact of COVID-19 pandemic on colorectal cancer screening? And we are absolutely going to build in some time for questions. So as you saw pop up in the chat, we are recording this, and the replay will be posted on our website. So we've put together the dream team once again, who've been so gracious to give us their time and to come back together to see where we are a year into the pandemic. Dr. Dorado Brooks, the Deputy Chief Medical Officer of the Screening Business Unit at Exact Sciences. Dr. Rachel Osaka, Assistant Professor at the Fred Hutchinson Cancer Research Center at the University of Washington. Dr. Stephen Itzkowitz, who's the Professor of Medicine and Oncologic Sciences, Director of the GI Fellowship Program at the Icahn School of Medicine at Mount Sinai, and on our steering committee. Dr. Laura Makaroff, Senior Vice President of Prevention and Early Detection at the American Cancer Society. Michael Sapienza, the CEO of the Colorectal Cancer Alliance, and myself, Rich Wender, who chairs the National Colorectal Cancer Roundtable and also chairs the Department of Family Medicine and Community Health at the University of Pennsylvania. So a big thank you to our panelists who you'll see live in just a moment. Not many slides presentations this time around. It's going to be mainly discussion. I'm just going to set the stage with some slides to start. Little housekeeping, as we said, the event's being recorded. The replay will be available on our website of nccrt.org. The participants are muted. Too many folks to do it any other way. We're well over 100, so thanks for being on. So we're going to take questions through the question and answer box. You can put them in there at any time. Emily Bell from the Roundtable staff is going to be monitoring that, and if you have any technical problems that pop up, don't hesitate to use it. And we are going to provide evaluation, and that's how we get better. So please do take some time and complete the evaluation when we're done. Thanks. Oh, yes, I'm sorry. There was a statement there about funding, and I'm sorry for missing that. But the CDC absolutely helped with funding with this, and really appreciate that support. Thank you for that. So let me do a little level setting. And as I said, this is going to be mainly a discussion panel, but I did think, particularly for those who may not have been watching this landscape quite as closely or who were not on our previous webinar, it would be really useful to look at the current landscape and see where we are with the pandemic. So let's do just that. Next. So first of all, I really can't capture adequately how remarkable the response was to March Colorectal Cancer Awareness Month. You know, if there was ever a time where we could have relaxed, could have changed our focus, so many people who are coping and exhausted with our response to COVID, this would have been the month. But let me assure you that was not the case. People were incredibly engaged. There were lots of brilliant and enthusiastic responses, ideas, all focused on promoting colorectal cancer screening during our Colorectal Cancer Awareness Month. So huge shout out to those of you who are participating today, who came up with some brilliant ideas of how to keep the cause moving forward. So this is one slide that kind of summarizes a huge amount of information that most of you, I think, have lived through uh, and are still coping with. And it's all taken all together. It really talks about the impact of COVID-19 on future cancer outcomes. So initially, and we all remember this vividly, when the pandemic first started a year ago now, uh, there was a dramatic and rapid reduction in access to care. Uh, there was fear of infection, both on the parts of the people providing the care and on patients seeking care. Um, Healthcare resources got reallocated to make sure that we were taking care of COVID patients. Uh, Loss of jobs began very quickly into the pandemic, and with that, a loss of both financial security and employer-based health insurance. Um, and then issues like transportation and all sorts of other shutdowns and requirement for social distancing all led to really a stunning and unprecedented reduction in the use of healthcare resources of all kinds, particularly preventive care. Uh, if people were going to access care, it was going to be far more likely for only for emergencies. So that led, as you all know, to a delay in routine care, preventive visits, screening, but not just preventive care and screening. There was also a reduction in the people who were getting the follow-up care they needed for an abnormal initial test, whether it be a mammogram or a FIT test for colorectal screening. Uh, and there were even patients, we all know this, who had important symptoms that warranted immediate evaluation who delayed that. As a result, we're now seeing later stage diagnosis, which all of us know has a lower probability of cure and of long-term survival with fewer treatment options and a greater demand for intensive treatment. Uh, and part of that it was individuals who delayed or modified their treatment. I also could tell you, I was talking to some colleagues yesterday about burnout among clinicians um, that resulted in some unexpected early retirements, all of which impacted access. So surgery, radiation, chemotherapy got delayed. There were changes in the chemotherapy regimen that were non-standard, and taken all together, we know that that's going to contribute to higher cancer mortality, probably of all cancers, certainly for the cancers amenable to screening like colorectal cancer. And actually, there's an effort right now to update the work that the National Cancer Institute did 10 months ago that projected we'd lose about 4,500 individuals prematurely from colorectal cancers because of the delay in screening. But we need to update that work. Unfortunately, we know that that number is going to be much higher than in the first estimate. Next. It, we also know that disparities, which have been present in every aspect of healthcare for as long as healthcare this country's existed, uh, really were highlighted and personalized and illustrated in a profound way in our response to COVID-19. So if you look at cases, hospitalizations, and deaths, uh, they were clearly higher for Hispanic, Latino persons, American Indian, Alaska Natives, Black or African American, non-Hispanic uh, populations. And there were so many factors for that that we've talked about before. Next. Uh, One of the other really dramatic uh, factors, which frankly I think we really don't know what the full impact will be, and it is changing at such an extraordinary pace, and that is in civilian unemployment rates, which have been highest for Black populations, next for Hispanic or Latino. These are unemployment rates, and you can see this extraordinary increase and literally overnight almost increase in unemployment rates when COVID hit in 2020, highest in the Hispanic population. But if you actually look at the degree of recovery, it's been a little bit greater in the Hispanic population. And once again, the Black population has had the lowest recovery in employment. I did see that there's some progress with new unemployment claims this month, so hopefully we'll see some progress with that. Next. So in the light of all of that, we put together our playbook in partnership with the NCCRT and the Colorectal Cancer Alliance to really drive action to increase screening and cope with the barriers presented by the COVID-19 pandemic. So we really aim to align our NCCRT members and our pledge partners and everyone who advocates for CRC screening. It had 4 main strategies and sections of assessing impact, identifying inequities, tracking recovery, and anticipating challenges. It really has provided a very strong guide, and I'll show you some data about that in just a moment. Next, please. In fact, here was the response to the playbook. It's really tremendous. There were over 400 participants in the July 2020 Playbook announcement webinar. The resource page has become the 3rd most visited page on nccrt.org and the top downloaded resource this year. Over 1,700 downloads since that June 30th, 2020 launch. And our supplemental sample letter for primary care had 662 downloads. So this really was meeting a need. Next. We also just are gathering the results from our NCCRT partner survey findings. And as you know, if you've been a member of the roundtable, we do an annual partner survey that Emily Bell organizes and leads. So take a look at these data. They're really important. 68% of the organizations responding have taken on new work or new staff, which is fantastic. But 45% have experienced budget reductions. And by the way, when I say 68% have taken on new work or staff, it may be to specifically respond to COVID and actually taken them away from core missions. We don't know the answer to that. 37% have experienced staff cuts or freezes, over 1/3 of all the organizations reporting. 77% have seen limited or decreased screening activities. No surprise there, we saw that happen in real time. And 78% who've been tracking this have seen declines in screening rates. It's shocking that it's not 100%, although I know there have been tremendous activities to kind of get back. The participants were NCCRT members and pledge partners. Next. I just want to end with this final slide just to call out, give a shout out to all of the organizations and individuals and people who, despite the challenges we faced, have stayed committed to increasing screening rates, recognizing that failing to do so would multiply an already stunning and unacceptably high burden of COVID by adding other avoidable deaths, deaths from multiple cancers that are amenable to screening, with colorectal cancer being one of the most important and one of the ones most impacted by the pandemic. So people are they're still in there. They still want to make a difference. And I think people have never been more ready and eager to get back to screening. So with that, let's all take our panel that I introduced earlier, and everybody can show their faces, and we'll all be on this group together. So welcome, everyone. Steve, Rachel, Dorado, Michael, Laura, Angela, fantastic to have you aboard. And let's kind of get at it. So I want to start by kind of calling on each of you to, one, just thank you for being here. Let's kind of start where we left off, which is with the playbook itself. I've already showed you, we've seen quite a bit of interest. Lots of recommendations put forth to strengthen our response and not lose momentum on CRC screening. And I'm curious, as a starting place, to maybe call out some areas that really have been encouraging, where we really have seen people take that very seriously and adopt it to their settings. So Rachel, maybe I'd call on you to kind of kick us off.
Sure. Thank you so much. It's a pleasure to be back with this group and to join the NCCRT and all of its partners to have this conversation. Almost a year ago when we met, one of the major points of conversation was around the opportunity to increase screening participation through stool-based testing. And I would say that what we've now learned almost a year later is that, there are definitely some successes and some areas for improvement. Anecdotally, what I'm discovering in conversations with individuals at large healthcare systems are that those that were set up to deliver these stool-based tests in a population sort of based manner did do so. And actually, the VA system is a great example where they increased their use of mailed FIT tests in order to improve colon cancer screening. Within our own healthcare system, what you mentioned, Steve, as far as staffing and budgetary losses and cuts, we definitely felt that here locally. And as a result, while we couldn't do mailed FIT in a population-based manner, many of the clinics were reaching out to patients and were mailing those FIT kits to patients directly as a way to encourage them to complete screening. So I think as we move forward, certainly there's still a lot of room and opportunity. We know the pandemic has not ended and it's not going away. And what we see are that healthcare systems are investing those resources to create infrastructures to allow them to respond in this way during this pandemic and for future episodes as well.
Yeah, it's a great point, Rachel. Something we'll talk about in the group discussion as to what will be sustained. What will never quite be the same, and this area might very well be one of them. So, Steve, you guys in New York were right in the middle of that, in a way that almost no other city was in that first wave, and that was before we knew very much about how to cope with the pandemic. So we kind of learned on the backs of New York. Tell us a little bit about the GI community and what you've observed.
Thanks, Rich. And again, it's a pleasure to be part of this conversation, I guess 9 months later. From a colonoscopy perspective and a GI perspective, last summer, all the endoscopy units in the country basically had to pivot all of their efforts to treating people who were very gravely ill, and all screening pretty much shut down. And as endoscopy units started to reopen in the mid to late summer, of course, patients were still afraid to come in. And if we recall, a lot of that was not only the fear of the virus, but also unavailability of testing. And in order to get people in for colonoscopies, just about every endoscopy unit I know required that patients get a COVID test that was negative in order to come in for a screening procedure. So that was pretty limiting for a few months. I think now testing is much, much more available, and the turnaround time for testing has improved. So that allowed endoscopy units to open up eventually. And the other thing that a lot of endoscopy units did was, as they were opening, they prioritized. So people who had symptoms had to be scoped first, positive FIT or a multi-target stool DNA test, those people had to come in. So I think we all got pretty smart about sort of really triaging the quote screening population. At this point in the spring of 2021, I think most endoscopy suites are back up and running. I think the volume has returned almost to normal or pretty close to it. If there's a strain on endoscopy suites now, in large part, that's because there are still some endoscopy staff that get pulled to cover COVID units. And so sometimes there's a staffing shortage, but I don't think that the COVID testing is that much of a barrier any longer. I think patients' fears are greatly reduced, especially now that we have vaccines. So I think we're really starting to breathe a little bit deeper now. I just would put in a word about CT colonography. Just like stool-based testing can be done remotely, although CTC is not done remotely, patients have to come in. There's actually, fewer staff that really were put at risk during the pandemic. Patients would come in And of course, the technician would be responsible for doing the test, but then the radiologist could read it without having direct contact with the patient. And I think we sometimes forget about the value of CT colonography for screening. So just something to always keep in mind. And even now that things are opening back up again, to consider whether or not in your environment, CT colonography would be an important addition. So I'll wait for further questions.
Steve, those are just terrific points. And again, maybe some lasting changes. I do keep worrying about this small percentage of people who are still facing, whether it's loss of insurance or whatever, that may be hard to reach that last 3 to 5%. I'm going to turn to you, Dorado. We've been talking about the policy barrier screening for a long time. And I think there were some people who recognized that this might be a moment where there would be some receptivity to policy change. So give us an update on where we are with that.
Absolutely. And I'm sure that most or maybe everybody on the line is aware of one of the big wins that we've experienced, and that is the finally getting passage of the Removing Barriers to Colorectal Cancer Screening Act to close the Medicare loophole. That was actually included in the December 20th, December 2020 COVID relief bill. So it really does fall under that COVID mantle, fortunately. But we still have big problems with the follow-up colonoscopy, and that's a policy issue that remains to be addressed. But also a number of other very positive things. We know that early in the pandemic, CMS relaxed a number of its regulations to try to increase access to care, COVID-related specifically, but really for all kind of aspects to care, particularly telehealth services. And we saw the huge rise in virtual care and telehealth services early in the pandemic, but much of that has sustained. We've not gone back to our baseline of 0.5% of care being practiced by telehealth in many environments. And there are now there's legislation that's been introduced to try to extend or eliminate some of those pre-pandemic barriers to telehealth that were part of our legislation, part of CMS rules. And actually, both at the federal level, and I know here in Texas, there has been legislation introduced as well to try to increase telehealth access. In addition, the American Rescue Plan Act of 2021 addressed some of the issues that you've already mentioned, the financial challenges people are facing, one, by expanding access to and the timelines for people to sign up for health insurance through the marketplaces. And also a second element that will provide 100% coverage of COBRA premiums for individuals who lost their job during the pandemic. So a real effort to try to avoid a huge rise in the uninsured population. And then finally, on another policy approach, but really policy and practice, the Commission on Cancer worked with the American Cancer Society and a variety of other organizations to introduce a Return to Cancer Screening Quality Improvement Project. And participation in this project allows systems to get credit for a variety of different COC standards by taking on the return to screening kind of activities that we promoted in the Reigniting tool. So I think that there have been a lot of very positive advances on the policy front, and look forward to more conversation.
Yeah, it's fantastic. Let's keep driving the benefit of that. Rachel, maybe on a little bit less positive side, or maybe a lot less positive, it's not like disparities just started to occur when COVID came along. I mean, they highlighted them in a unique way. But it's been a major focus of our 80% in every community endeavor. So, share some thoughts on what we might be able to do to recognize and really proactively prevent even further widening in our disparities in screening.
Yeah, so, 9 months ago or really a year ago, when the initial estimates were being released about what we suspected would be the impact of this pandemic on screening and subsequent diagnoses as well as mortality, we saw data that showed that likely colon cancer diagnoses would go down and cases would go up, and later stage disease and death as well. And now, a year later, we're starting to see health system data that is in fact confirming those suspicions in a really bothersome way. So in a paper written by Mohammed Bilal and his colleagues, looking at a large health HMO plan, health management plan organization in the East Coast, what they found was that colon cancer screenings and colon cancer cases actually being diagnosed this year compared to last had decreased by almost 40%. Similar numbers for pancreatic cancer diagnoses and esophageal cancer diagnoses. And what that finding was consistent when they looked at years prior. So when you compare 2020 to 2017, 18, 19, the decrease was very clear and quite dramatic. And because we know that many of these diseases disproportionately affect racial and ethnic minorities, there's no reason not to believe that those who are going to be showing up and dying from these cancers are going to be racial and ethnic minorities, as well as those who have lower socioeconomic status. So, as far as what can we do, we've already touched upon this. For colon cancer, at least, when we have multiple screening modalities, really maximizing the use of those at-home tests and some of those tests that require less touch, as Dr. Iskowitz mentioned. How can we, continue to engage with communities in a real way, even though we can't do it in person? And I would say that many of the organizations that we partner with have been doing an excellent job with this past year, regarding, electronic events and Zoom events. We've seen the partnerships that the Colorectal Cancer Alliance has created with organizations like Black Health, which are promoting fit screening and just increasing awareness of screening in Black communities. So we need more of that in order to continue to educate the community about the importance of not putting off screening, even during this time. And then finally, as we move forward, all of our practices need to be proactive. Here within my organization, we recently looked at individuals who had had their procedures delayed or canceled at the height of the pandemic. And we found that almost half of those individuals had yet to return. And of those that did return, about 5% were diagnosed with new colorectal, esophageal, and pancreatic cancers. So and there was a paper in Gastro of a survey of practices around the country at the peak of the pandemic that really evidenced that practices hadn't come up with plans for how to manage those individuals to ensure that they weren't lost to follow-up. So I would encourage all of our primary care as well as our gastroenterology practices to make sure that we're going back and looking through those individuals whose screenings were delayed, whose procedures were canceled, and really putting every resource towards making sure that those individuals return. Again, all in an effort to reduce the disparities that will unfortunately will likely continue to rise.
Yeah, thank you. It's a very sobering statistics that unfortunately resonate with our experience here at Penn as well. Despite the progress that we're making in getting back, we recognize that there's a whole cadre that we're not sure we're being very successful at re-engaging. So Laura, there's probably nothing that changed on a dime more rapidly than the use of telehealth. And few things that I think are kind of as complex to understand of where telehealth sits as a facilitator of screening, a barrier to screening, an opportunity, So good luck with tackling telehealth, but really a critical issue.
Yeah, so critical. And like Dorado mentioned, I think the ongoing sustained policy solutions to support adequate reimbursement for telehealth is going to be so necessary, but recognizing that this is a moment in time that maybe we've all been looking for so long, of how do we reduce barriers in access to care through the use of technology like telehealth, and that being able to talk about screening and give a screening recommendation through telehealth visits is so important. Being able to utilize telehealth for preventive visits and annual wellness visits, which is so new, right? I mean, it's not the way that I have necessarily thought about telehealth as a primary care doc, nor have we necessarily had the right workflows or clinical processes to do that, but being able to build that in And then being able to think about how do we incorporate things we know work, like standing orders. So in a clinic setting, a standing order, the MA starts the conversation, I walk into the room, but how does that work in a telehealth visit? And how can you use things through your EHR to like do that pre-visit planning or pre-charting that's so helpful to really facilitate that a screening discussion happens and that the appropriate test is ordered. And then certainly building in the processes of what do you do with FIT tests, which of course, and multi-target stool DNA tests, of course, are such an important part of the solution, but how do we ensure that the FIT test gets to the patient through a telehealth visit, utilizing what we know from mailed FITs and other processes like that, utilizing screening navigators to ensure that the tests are completed appropriately and returned and all of the follow-up happens. So it seems to me like we know so much that can be adapted and used within telehealth. We just have to kind of keep our creative, innovative minds working to build those new processes and workflows into everyday care.
Yeah, thanks. You know, we're also seeing some of the ending of the interstate facilitation. You know, they're putting back into place restrictions on seeing people out of state, and that's a frustration, I think. And I'm not sure what the true benefit is from a health standpoint, maybe or at the state level. So another thing we're going to have to kind of get a handle on. But really, it's, you know, just a fascinating area. So Michael, you know, as complicated as all these things are, getting in touch with where people are, you know, in their attitudes towards screening and their healthcare, it's tough. I mean, it's all over the map. So, but I'm confident that you can help us kind of think it through. You know, what kind of messaging do we need to do? What's your sense of how we have to interact with people in a new way?
Yeah, absolutely, Rich. You know, I think number one is we've been finding that people are sick of COVID-19 messages. So, you know, whereas when we were talking before, it was like, COVID-19 keeps you at home, but you need to get screened, et cetera. But those messages we're finding for the general population are not working anymore. It is not getting their attention. I think what really is still getting people's attention because, you know, we're still seeing this hesitancy. You know, before the pandemic, people were reticent to get screened in the first place. And we think that the pandemic, you know, human behavior is such that, you know, it's learned, right? And so when we're home for a year, what happens? So, you know, we've really been, you know, seeing and hearing that, you know, having options is really what is helping drive potentially the average risk folk to get screened. And then the second piece is that if you are at high risk, that making sure that you continue to talk about the safety of endoscopy suites, hospital systems, et cetera, is really speaking to patients.
Yeah, tremendous. We'll talk a little bit more about that, Michael, as we go forward. In fact, thank you all for those really good insights about some success areas, some very positive areas, but some ongoing challenges. I want to turn, as we promised in the opening, we made a pledge to our over 150 participants that we were going to be pretty concrete. So I'd like to, and I'm just going to open this up to the group. So just take yourself off mute and chime in. To really share in a bulleted way some successful examples, some specific interventions that you've seen be effective and work. I'll kick us off because we've been looking at our screening rates here at Penn, and this is an enterprise-wide goal. So I mean, it's a high priority item, and we're absolutely committed that there not be any disparity based on being Black or any other group, and we've done fairly well there. But we're behind in our goal, not by a lot. So we have just kicked off what we call an end of year, you know, push. And we're literally reaching out to every entity within our 6-hospital system. We're reaching out to every office, including other disciplines who didn't used to give out FIT, that they can give out FIT. We're doing renewed mailed FIT. We're doing more text messaging. So I'm just going to open it up to the group. What are some of the really cool things you've seen that you think that are making a difference?
Rich, I can start. Actually, in Philadelphia, we've been working with African American radio station, WURD, before the pandemic, it was going to be actually having live events. They have tons of community events all over Philadelphia, mainly for African Americans. And we actually pivoted that to they're having a bunch of virtual, health events and others. Participating with LabCorp, Independence Blue Cross Blue Shield, the Alliance, and providing free fit tests to anybody that wants them. And then obviously we have a prescribing physician, from general practices within Philadelphia, and we're really seeing a huge uptick in the use of this program, which we're really excited to see. And then the Alliance, through, as Rachel said, through this partnership with Black Health and Cottonelle, is able to provide any positive fit tests with colonoscopy. So it's just a kind of an example. We're hoping to replicate that across the country as well.
That is awesome. Love it. Perfect example. Other thoughts?
I'll share. So within our health system, as I mentioned, because of some of these financial losses and loss of staff to coordinate things in a central way, the primary care clinics really took ownership of wanting to keep up screening rates, reaching out to patients, mailing them those fit kits. And so even though we've seen a slight decrease across our health system in colon cancer screening, we're actually still doing quite well compared to a year ago, which I'm very pleased to see. And then from a community engagement perspective, myself and 10 other colleagues around the country, we created an organization called the Association of Black Gastroenterologists and Hepatologists. And we've been able to engage with Black community in a really profound way. One of our very first events was a community conversation where we had colorectal cancer survivors come and share their stories with the general community about, ways they were diagnosed and what symptoms they experienced. And the feedback has been just tremendously positive from that. And so seeing communities really engaged, wanting to go in and get their screening tests, understanding that, they should still complete screening has been really quite rewarding.
That's tremendous. So, I know there's some others, but I'm kind of curious a little bit, Steve and Rachel, as the two folks on the panel who actually do colonoscopy. What's your sense of what the attitude is right now? And I know that this is changing. For example, there's some discussion that I've heard that as patients get vaccinated, the recommendation for doing COVID testing before the procedure will change. And that there's actually not a lot of evidence that doing the COVID testing changes the risk anyway. But that's great for our perspective. I'm not sure how the general public is reacting and thinking about that. So maybe I could put both of you on the spot to comment a little bit about where we are with the perceptions around colonoscopy and really concrete ways to make sure that this test is available, accessible, and people are willing to do it.
Maybe I'll take that. So, vaccinations in New York City, at least, are picking up. And I think with people being vaccinated, there's less pressure to, feel nervous about having to get a COVID test. Having said that, our endoscopy units in our network are still requiring negative COVID tests, even in people who might have been vaccinated. But I think the staff in the endoscopy suites are feeling much more reassured. Most staff have already been vaccinated themselves as well. So I think we're at a point in time where we don't really know whether we can sort of forego or let go of the COVID testing, because it's been a huge barrier. Just getting that COVID test resulted in enough time before the procedure time. I think this is all going to settle out and will improve in the next couple of months. So I'm optimistic about that. There's a lot of hesitancy still about getting vaccinated on the part of patients, and we're well aware of that and some of the hiccups with some of the vaccines. I predict that that's going to produce or result in a little bit of issues with patients coming in for routine screening if they haven't been vaccinated yet. But I think it's all going to improve, and we're seeing that. We're seeing the volume really go up in our endoscopy suites.
Rachel, anything to add to that?
Yeah, I would say, certainly in my practice, at least, of all the hundreds of COVID tests I've done in the past 9 months pre-endoscopy, I've actually only had one turn up as positive. And so, I haven't heard conversations yet around waiving that requirement for individuals who are vaccinated, but I think that would certainly ease and make the process of, getting in the endoscopy suite much easier. So I look forward to our GI societies and other, organizing bodies having that conversation. As far as you mentioned procedure volumes, we're sort of running into challenges with the endoscopy suites being capable of performing procedures to the pre-pandemic volumes, but our space either being used by COVID positive patients or staff being pulled into to help serve on COVID units. So I think until, either the rates of infection in this country are much lower or the rates of vaccination are much higher, we're going to continue to run into challenges around that. And that certainly sort of leads to some patient hesitancy as well. So I think it's just a constant conversation with patients, making sure that they're reassured and know that it's safe for them to come, understanding that there may be some limitations because of system recommendations and or the COVID infection itself.
Yeah. So let me just take a pause. I have a couple more specific questions, but I want to take a pause for others on the panel if there's some really cool ideas that they wanted to share in any of these domains.
I was just going to share from a national perspective at the American Cancer Society, certainly this issue of helping people get back to screening, all kinds of screening, including colon cancer screening, is so important. And we have done some a various little bit of market research about effective messages that help people activate towards screening. I can put the link in the chat for that resource. It's available. It was a quick look at what the public resonated with the public, and it really matches what Michael was speaking to, that people are getting kind of tired of the messages about COVID and the pandemic, which was so interesting because we did the market research in December, which was like the height of surges. So it was really unexpected to me. That was unexpected to me, but it was really interesting to learn that. But there are some great messages in this guidebook. Feel free to use those in your settings, how they would fit. And we did a little bit of subpopulation looks at what kind of messages work better in different subpopulations. So that's one thing we're seeing some good use of. People seem to like it. We're seeing lots of downloads of that resource. So that's been really great to see.
That's awesome. Yeah, I'll just add one final thing, and before we kind of move to another question about telehealth. And Laura, I thought your earlier comments were right on. As a way to get general access, it's been tremendous. And part of general access is certainly we could then order a colonoscopy, right? Even if you don't have the workforce, the flow to get them a fit kit smoothly. And one of the cool things is that we had a lot of snow in the Northeast and Philadelphia area. And for the first time that I can remember in all of primary care, we just looked at the weather reports and we got the staff, we called every patient the day before, and we switched 80% of those visits that would have otherwise been canceled, became telehealth visits.
Yeah,
so, it's a tremendous access change and a good sustained change. I'm going to put you kind of all on the spot. And by the way, I see the questions coming into the chat, and in just a couple of minutes, we're going to be all about your questions. So this is a good time to be putting questions in, and we're going to try to get through as many of them as we can. I'll probably just call on one person to answer each one. So this is a tough assignment, ladies and gentlemen, because I'm only looking for 2 to 3 sentences from each person, which is kind of a one final thought. As we're really trying to get back to 80% in every community, one message, one opportunity, one barrier we need to get going, 2 to 3 sentences. So tough assignment, but I'll put you all on the spot to do it. So who'd like to go first? Dorado's mic is off, so I might have to call on him. All right, Dorado.
I'll go for it. Options, options, options. I think that it is imperative that we continue to recognize colonoscopy is a great tool. A lot of limitations right now. Steve talked about Ct Colonography as an option. There's been a lot of talk about FIT and then MTSDNA or Cologuard. but making sure patients know that they have other options beyond colonoscopy if they can't get or don't want a colonoscopy.
Love that one, Dorado. I think that needs to be a sustained message. Who's next?
I can go, Rich. I think going back to what Rachel was saying about access. I mean, we really, I think, all have to play a part in making sure that all financial barriers, time barriers, et cetera, are overcome. I mean, not just pre-pandemic, as you were saying earlier, Rich, but now moving forward. I mean, we were lucky enough. Exact Sciences has donated $1 million worth of free tests. Let's Get Checked has donated $1 million worth of fit tests, and Black Health and Cottonelle have donated, I think, about $300,000 worth of colonoscopies to reach all for underserved populations. So we're working really hard at the community level to make sure that those things happen.
Yeah, I love that. Fantastic. Laura.
Yeah, thanks. Tough assignment. Well, let me see what I can do. I think my word would be prioritize, meaning recognize, like so many people spoke to, the people who maybe were delayed or missed or have other risk factors, as well as prioritizing populations we know have disproportionate burden of disease and making sure we find them either through zip codes and unique ways of looking at that, or race, ethnicity, or other ways to use your data to prioritize and get your patients back in.
Yeah, I'll pile onto that one just to say we've been looking at really carefully at our data with positive stool tests, either the Cologuard test, FIT test, and we've found that the follow-up colonoscopy rate has not where it needs to be. So we're really putting a high priority on that group. Rachel.
It's tough to go last. They took all of my answers, but I would
Steve
echo.
Still have to go. Steve is behind you.
I would echo what Laura said, which is definitely prioritizing high-risk populations, really to minimize disparities. We need proactive measures, including tracking those who've been canceled, so we don't lose individuals and have even more cancers and more later stage disease. And we need to plan. We have evidence-based tools that we can utilize in a more substantial way, not only for this pandemic that has yet to end, but for any future pandemics as well.
Yeah, wonderful. Steve.
I guess the last thing I would add is know your microenvironment where you work, understand from the primary care or internal medicine practices how you're reaching patients who need screening. Make sure that there's communication between the gastroenterologists or the endoscopy units and the referring doctors, because every microenvironment does things differently. So understand how your microenvironment functions and set up systems for tracking. We're doing a lot of stool-based testing because it's easier to do at home, but are you tracking the positives? Are you tracking the negatives? And so setting up tracking systems, but communicating, understanding your microenvironment, and then communication between the endoscopists and the referring doctors.
Wonderful. Yeah, data track, if we're really not measuring, tracking, using our data, we have all learned the lessons over the years that we just don't see the improvements in rates that are possible. So whether the news is good or bad, you've got to be tracking it. So I love that. So thank you so much to the panel. Those were fantastic. We're going to try to get through some comments and questions as much as we can. I'll do my best. So the first one is really an interesting one. And I'm not going to read the whole comment. It's I think a nurse practitioner, I think that's what that be, student working on a project at an FQHC. And, we've talked about these very large population, ethnic racial groups, huge group saying Latinx or Hispanic, Black, which of course contains within it enormous diversity. They're not just simple homogenous populations. And this question was about a FQHC with heavy Arabic and Bengali populations and very, very low screening rates to start. Cultural barriers, health literacy issues, language barriers. There was an interesting talk about their clinic responding really well to incentive-based interventions in getting flu vaccine and looking at something similar in CRC. So let me just open it up to one or two of you to comment on what's a good starting place when you're working with an FQHC that's really, just facing enormous barriers but wants to get get going and really improve rates?
I'll start. I don't know much about the Arabic population, frankly, but I think that that's the first thing, is to figure out what their perceptions of colorectal cancer screening are. What are the perceptions among those patients, and what might be serving as barriers? Is it just a lack of knowledge about colorectal cancer, or not knowing how influential a screening can be, or are there other kinds of cultural issues that need to be considered as you're trying to educate and move people toward getting screened?
Yeah, I would highlight that, Dorado. In New York City with the C5 Coalition about 15 years ago, we were making tremendous inroads with Black, Hispanic, even Asian populations. But when we did analyses, we found that the Russian population was really lagging behind. And when we dug into this, we learned that many people who are fairly recent immigrants from Russia, the concept of preventing a disease in general was very foreign to them. They didn't think that you could prevent a colon cancer. So there was a lot of patient education. And we did a lot of messaging around that and educating you can prevent colon cancer. And then we saw the rates go up, but we had to do a very targeted, and we got some people from that community to serve as spokespeople. So, you're right, understanding the cultural values and the educational values in a given population, and trying to get champions from that population.
Terrific. Yeah, I really like this next question. I thought it was very relevant to both in a pre-pandemic, a current pandemic, and a post-pandemic world. The relevance is still there. It's a question we've been asking for years. I'm still hearing of health systems that are not open to home-based FIT and only want to focus on colonoscopy. Are there new studies or research about the benefits and the comparable benefits of these different strategies that could be used to convince systems that they need to embrace them? Partly it's the gap in screening that needs to be bridged, but I think there is real questions about what is the comparable efficacy of different systems of screening?
I can start. So there are no head-to-head comparison trials that have been published comparing FIT to colonoscopy, but there are 4 underway. And so we should hopefully have some more information about that soon. I guess this is a perfect question for me to talk about one of our recent studies where we looked at, what would be the impact of increasing mailed FIT over the next 3 years, presuming that it would take about 3 years for us to completely return to normal. This is a modeling study, and so keep that in mind. But in our study, what we found was that if COVID persisted and continued to impact colon cancer screening, that screening rates could, that up to like 43% of people who needed to be screened would not get screening. But if you increase FIT a modest amount from just 15% where we are right now as a country to about 22%, you could bring that number down to 29%. So that's about a 35% decrease just by modestly increasing FIT. Of course, that doesn't take into consideration implementing those strategies around mail distribution as we've talked about, but I think it provides data for health systems to plan for and to determine what resources they need during this pandemic to help ensure that we minimize losses to screening and follow-up.
And as Rachel said, we just don't have that head-to-head data, but Exact similarly has done some modeling work using what we view as real-world evidence, that is evidence based on studies that have been done looking at the likelihood of adhering to Cologuard versus FIT versus colonoscopy, and also the impact of a colonoscopy after a positive stool test versus using general screening colonoscopy, and the higher yield for colonoscopy after an abnormal screening, stool screening test. So there, and some of this data has been published, other will be coming out soon. So there's a growing body of data, I think, that health systems can look at. And then I think just looking at what's already there, you look at what's happened with Kaiser. They have documented the fact that they hit a plateau when they focused on colonoscopy, and they were only able to get up to and above 80% by adding in the additional options for their patients.
Yeah, it's a tremendous point. It's been universally experienced. Steve, the C5 experience, which was very colonoscopy heavy, and then recognized the need to expand options in New York City. So this is an interesting question that we do face a lot, and that's this issue around colonoscopy, around transportation, and the need to have somebody accompany you home. How are people handling that with homeless populations, people who face real barriers? Are there some innovative ways that people have dealt with either transportation or longer observation within the facility so that they might be able to, more safely able to leave?
We encounter this within our safety net health system. And one of the strategies that has been effective is to have in-hospital respite care, where individuals are able to come in the night before and complete their bowel prep. And then they do get observed for a longer period of time before being discharged home. And that's done in coordination with our social workers and other support staff.
Cool. I could. Steve, anything you want to add to that? I saw you originally came off, but.
Yeah, no, obviously, it's a huge barrier when you're dealing with the homeless population, but at least in New York City, where I work, there are a lot of ambulatory endoscopy suites that serve people who are underinsured or uninsured. And we can watch them longer in the unit and release them without an escort if that's what we have to do. Ideally, we always like to have people have an escort, but it can be done even without an escort. And that actually gets also back to the notion of CT colonography again, because with CTC, there's no sedation. And the patients can have the test, get up and go about their business. And that's something to think about. I realize that it may not be as universally done, but if that's one of your barriers, it's worth considering, because there's no sedation and there's no need for an escort.
Yeah, and then if those people need colonoscopy, at that point, you have a very high risk patient with an abnormal CTC. Great point. Well, we have some tremendous questions. We're not going to get through them all, but I may put the panel on the spot to get some email follow-up out on the website. Two questions that maybe we can touch real quickly. One is the worry that if on primary care, kind of in the community setting, with close GI colleagues, that if they switch too much to fit, it's going to hurt the business relationships with the GI docs. Is that a real concern, or do you think there's plenty of colonoscopy demand to go around?
Well, I think if providers look at their own practice, unless they're at an 85 or 90% screening rate, there are a lot of patients who just aren't getting screened. And some of the data, again, that has been shown, at least for Cologuard, is that I believe in one Medicare study, about 48% of the patients who completed Cologuard were previously unscreened. So we're talking about bringing new people into the fold, not replacing folks who are already there.
Yeah, I think that's a great spot. And for the sake of time, I think that's I'll leave it there. That there's lots of people we need to be screening and use all of these methods. There was a really interesting comment about using the opportunities while people are waiting for COVID after their vaccine to talk about other healthcare needs. I think it would be hard to combine with CRC screening. I know people have thought about that, but general health messaging during that 15-minute wait time is pretty creative. I think that's a pretty good idea, and you could include some general screening messages. That would be great. And the very, very final question in 30 seconds is, what is the likelihood that blood-based testing for CR screening will be an option in the next few years? And I think the answer is extremely high. There's enormous amount of work going on right now with different technologies for blood-based testing to screen for many cancers. The issues are quite different to screen for a disease like colorectal cancer, where we've already proven the benefit of screening, versus screening for a cancer like pancreas cancer, where we don't have proven options. Just remember that blood test is going to need to meet a very high threshold, because we have other good options. So we're not going to be able to accept anything but a really effective option. But let's face it, if we had a blood test that really worked, that could be very attractive for patients who won't agree to screen through any other way. Well, we're right at the end. I cannot thank the participants enough for joining us. Wonderful questions. Sorry we couldn't get to absolutely every one of them. But a really special shout out to our panelists who, as always, just knocked it out of the park. Really wonderful job for your guidance. And ultimately, a special thank you to each and every one of you and your teams who have done such tremendous job through COVID, before COVID, who've stayed committed to providing wonderful healthcare for our patients, for reducing disparities, and for continuing to increase screening for colorectal cancer as we strive for 80% in every community. Thanks for joining us, everybody. So long.
Thank you.